My name is Travis Gunderson. I'm a physical therapist based in Minnesota, Bloomington, Minnesota. Myself, me, and my colleague Terry Shimaluski, we were part of a bigger independent study course, and we kind of built out this course called Foundations for Psychologically Informed Practice for Musculoskeletal Disorders. So I'm a practicing physical therapist. I also teach at Bellin College in their fellowship program. Teach a course on pain science and psychosocial implications. So for the course today, I think we're gonna for this short course, we're gonna explain the scope of musculoskeletal pain in the U.S. and we'll introduce you to psychologically informed practice, which presented in the literature about 12 to 13 years ago. And we're really going to talk about and introduce you to foundational models within psychologically informed practice. And we'll then talk about some of the barriers that we've seen in implementing this type of care within PT practice. And then we'll end it with some strategies that you could take to the clinic even tomorrow, or start to think about how you approach patient care with these strategies. So let's first talk about the problem of musculoskeletal pain. The CDC had a paper that came out a few years ago, and they'd surveyed US adults, and around 20% of these adults reported having some chronic pain every day. And interestingly, about 7 to 8% of US adults have what's called high impact chronic pain. And that means that this pain keeps them from working. It impacts them every day socially, physically, and psychologically. And this is really important because in PT and physical therapy, especially for musculoskeletal PT, we're really focusing on physical impairments a lot. And unfortunately, as we look at the studies, there's not a great relationship between the physical impairments and pain. There's not a 1-to-1 ratio. So we kind of get stuck in the clinic a little bit on what to do. And it turns out that psychological domains can be super relevant for a lot of patients with chronic pain. And so that's really become a high research and clinical priority, is sorting out how we might impact folks. So the biomedical model you may be aware of, that's really formed a lot of PT care and treatment, and biomedicine has really dominated the treatment of musculoskeletal disorders like low back pain. So in the biomedical model, there's a disease process, and then you try to identify the cause of it. You make a name for it, like give it a diagnosis, and then the treatment should be directed at the cause, and the disease should go down. And we see this type of approach being used with low back pain care. And then we have some treatments that are not as useful, and some approaches to assessing low back pain that aren't really helpful that we see. And yet the biomedical model still dominates. So lumbar fusion, for example, for low back pain, the rates and use of fusion, unfortunately, this top graph is looking at 2004 to 2015. There's not a huge change in the rates of lumbar fusion for low back pain. And the Choosing Wisely campaign, Rosenberg reported on this in 2015. From 2010 to 2013, we really didn't see a big change in low back pain imaging, MRIs and such. For folks who have back pain, simple low back pain, no red flags, we're still getting high rates of use of MRI. And it just goes to show that the biomedical model still dominates. And we're really not doing a great job based off that CDC data. A lot of people still have pain. So the biopsychosocial model, it's not new. It was introduced in 1977, and maybe even before that. And it looks at the health experience a little broader. So it still has the biomedical factors in it, but also considers social and psych factors. So it's not to dismiss the role of biological and biomedical factors, but it can help us explain some of the limited effects of impairment-based PT approaches that we see in the clinic, or explain how folks who are getting lumbar fusions and aren't any better after it. It kind of explains how that could be the case. And what's cool about it is this model really could help PTs explore the variety of options and approaches that potentially could help and improve musculoskeletal outcomes. So I look at it, it's an opportunity to look at a bigger picture And we're going to continue to use and be precise with the use of the biomedical model. So we aren't throwing that away, but just taking a new vantage for this really tricky problem. And we really should, we don't want to say that it's like the most effective way. We still need to evaluate it and be skeptical, and using the model and treatments that come out of it still deserve intense scrutiny via the scientific method. So we're looking to be broad. We're not throwing the proverbial baby out with the bathwater. So there are limitations with the biomedical model that have been described. Louis Putindura and Adrian Lowe, in their book in 2012, kind of took Scott Haldeman, who was a spine surgeon, some ideas from him to say, what are these limitations? And if you look here on this line, we have the biomedical model, the blue line. And that really, if you look at that blue line, that's the assumption of the biomedical model, that a person will have symptoms or an illness, and that will progress in a line with the disease process. And then as you get farther into the disease process and you intervene right where this yellow line is, you'll turn that right back around proportionally. So the symptoms and the illness go together. That's kind of how the biomedical model, that's the assumption that it makes. But we run into a problem. If you look at the green line, how do we explain with the biomedical model patients that have a progression of disease on their testing? So think of like knee osteoarthritis. So they have progressive knee osteoarthritis, but actually their pain goes down with treatment, but their x-ray gets worse. How do we explain patients with low back pain? If we look at the gray line, how about this is patients with low back pain who don't get any better. In fact, they get worse, but all their MRI, their blood work, all their scans, everything is normal, so there's no progression of disease process, but their symptoms get worse. And so the biomedical model assumptions sort of fall flat. And for conditions like low back pain, it's much more likely that a person's disability, for example, will be linked with levels of fear and distress rather than the physical findings on imaging. So there is a need for a new way or a new kind of model where the assumptions are logical and can explain more of the things that we see. Here's the new way. Now, psychologically informed practice came in 2011 in PTJ, and it talked about this idea that we have mental health providers, psychologists, counselors, and they're focused on treating psychological distress. Their emphasis is on psychological factors. And then we have PTs and standard physical therapy. We're focused on identifying physical impairments, physical functional limitations, with an emphasis on the physical factors. And the idea of psychologically informed practice is that we could integrate the biomedical or the standard PT and the psychosocial approach to involve the patient beliefs, attitudes, emotional responses into our management plan. So we're going to ID individuals at high risk for chronic pain and disability, and then kind of provide targeted treatment aimed at the psychological factors as physical therapists. And we're going to integrate it into traditional impairment-based PT. So you can kind of see this, this grid where standard traditional care is layered in with these treatments that specifically target in an intentional way on certain psychological risk factors for chronic pain and disability, whether it's pain coping skills, like stress inoculation, thought challenging, problem solving, progressive muscle relaxation, and overarching all of this is patient-centered communication. So in this course that you get with AOPT, you're going to learn first about these foundational models which guide PIP, and models kind of serve three main purposes. So first, they're going to organize. These are complex patterns that we see. They're psychological models. The models organize complex patterns into practical and logical principles that can be used in research and used for clinical hypotheses that we get in the clinic. And these models can kind of guide us on how to look at the world. They're only as good as the assumptions and goals of the model. So if the assumptions are wrong, remember we had the biomedical model, but if the assumptions start to fall flat, we need to reevaluate. So it allows us to understand when our assumptions are wrong or incomplete so we can change course. That's one of the things these models do. And so we think, Terry and I think that understanding these models can help with the complexity and as we potentially integrate these concepts into clinical practice and research. So the first model, the original model that the PIP was framed off of was the cognitive behavioral model. This is back in the 60s and 70s that was developed in the psychological in the psychological profession. So this is pretty typical classical model where in a given situation, an individual will have a thought. That thought will create an emotion. That emotion will create a behavior, which potentially reinforces the thought. And the person kind of gets trapped in this cycle where their thought, emotion, behavior are reinforcing each other. So I just applied that here to something you might see in musculoskeletal physical therapy. So the condition is a rotator cuff tear. And the person's thought is that their tendon, the rotator cuff tendon, is vulnerable, and that produces an emotion. In this case, it might be fear or worry about movement because the tendon's vulnerable. That will produce a physiological response and create a behavior. And so the behavior in this case might be muscular tension to guard the arm, or they may avoid reaching overhead. And that reinforces, those behaviors reinforce the thought, the original thought that their tendon is vulnerable, which then produces the emotion. And this sort of cycle can be help us understand how people can get stuck into chronic pain and disability. So this model has linked with, many of you may have heard, this is often taught in PT school, the fear avoidance model. This is a pretty classic one by Johan Vlahan, introduced in 2000, and it works off of the cognitive behavioral model. It's been updated over time, but it allows clinicians and researchers a way to begin to think about how different aspects of fear might interact so that we can start to intervene. So in the original model, somebody would have pain, and then that would be seen as a threat, obviously, because it hurts. And the emotions of fear, catastrophization, and hypervigilance lead to avoidance, and that avoidance leads to depression and not using their body, atrophy, and subsequent disability, which then reinforces pain and the emotions. And so since then, it's been integrated. Bland and colleagues have integrated classical conditioning into this in terms of explaining how fear is acquired when there's pain. And the associative learning mechanisms are thought to be underlying this, and as well as the concept of pain sensitization through classical conditioning models. Now, this isn't gospel. These are just models to start to think about what we see in the clinic, and that can inform clinical hypotheses and research questions. So those are just two of the models that we go through, and you'll be able to get, we go through a number of the different models, all the way from, allostatic load all the way down to the trans-theoretical model. How you might be thinking, it makes sense that you might ask yourself how you might implement PIPs. And it is a good question, because PT training is historically biomedical. And if when PT programs in the US are surveyed, around 40% of directors are going to tell you that, or 60% of programs are going to tell you that they don't provide adequate training. Only 40% are saying that they do, in terms of pain management approaches that are consistent with PIP. This is a problem, because now that is going to reinforce more clinical instructors who are training PTs may ignore psychological approaches if they're not getting the original training. And then even in professional education or post-professional education, Seth Peterson showed in his assessment of continuing education courses that only around 10% of Con Ed courses are focusing on psych factor management. So we have a revolving door where we're not quite integrating these potentially important factors into our clinical care. So how can you get started? Great question. Glad you asked. I think, our course on foundations, and then subsequently the two other parts of the other modules of this independent study course are going to get in depth with that. And I just want to give a little overview, something maybe you could take back Monday morning or tomorrow morning, whenever, just kind of assess how you talk to patients, or you might consider how you communicate with patients. Patient-centered communication is an overarching theme of psychologically informed practice, and the models really start to help us understand that that is a big piece of it. So the first thing I want you to do is just look at these two, open and closed, and it's open and closed questions, and take a look at the open and closed questions to get a sense of how they feel for you. So on the bottom, it's, are you fearful of jumping from this box? Versus the open question is, what do you think will happen to your knee if you jump down from this box? One of them's closed, it's yes or no. The other one's open, non-yes or no. And the difference here is that closed are they're a little colder, right? They tend to lead patients to telling you all the reasons actually that they can't engage in the things that you want them to engage with. It limits them from expressing their motivations, and it leads to you telling them what to do. So, for example, asking them, did you do your exercises, actually can have the reverse intent. They'll tell you, either if they say no, they'll tend to tell you why they didn't do their exercises. Versus, tell me about your knee since our last visit. It's open, and it can lead to the patient telling you, why actually, if they didn't do their exercises, why they want to. Open is more inviting. It's more consistent with the therapeutic alliance, where the closed is inconsistent with the therapeutic alliance. And the therapeutic alliance, we know, is associated with better outcomes in the musculoskeletal world. The open question requires us to listen more, whereas the closed is going to limit their expression and desires and limit their ability to express their goals. And then there's a time and a place for a closed question, but in terms of gaining partnership, engaging the patient, the open question is going to be more valuable and consistent with PIP. So just consider how you're speaking with your patients in terms of the questions you asked, and this maybe is a way for you to start to evaluate that. Miller, Rolnick, and Butler, this is a part of motivational interviewing, and I encourage people to engage with specific training on that as they endeavor in their career. One further piece on patient communication that goes right with the open question is, the patient that comes back to us and you ask them, did you do your exercises? And they say, I only did my exercises once this week. I had so much going on. And in the old ways of communicating with patients, we might have this urge to sort of tell them what's right to do and tell them what to do, and tell them what's best for them. We have to get your quad stronger. I know you only did it once, but we got to get that quad stronger. We need more dosage of strengthening your thigh, or I really need to do your exercises more, or I think we should do this, or I want you to do that. Those sort of statements that you might notice come out of your mouth as you're speaking with patients just cue you to be aware of that. The new way of kind of responding to this is with listening statements. And these listening statements help the patient, it validates the patient. It validates their perspective and validates what they have going on, and will more likely to lead to them telling you why they should exercise versus you tell them why they should exercise. And when they start telling you all the reasons that they should exercise, or that they're going to exercise, the likelihood goes way up that they actually engage with the rehab and adhere to the rehab program. So I only did my exercises once this week. I had so much going on. You might say, it sounds like you really wanted to do your exercises. You think they're important, but you had other priorities come up. And right after that, the patient's going to go, if you got it right, they're going to go, yes, that's exactly right. And when they do that, you got them, because now you've just validated, now your therapeutic alliance is going up, and now the patient is ready to start to engage in the activities that you're ready for, that you want to do with them. So in summary, musculoskeletal pain is a big problem for U.S. healthcare. The biomedical model has a lot of limitations, and we have the biopsychosocial model that's been around for 4 decades. It's not new. But PIP is a little bit newer in the PT profession, and is kind of seen as a middle way between mental health, and in standard physical therapy. And so this course is really about foundational models to help you translate PIP, start to translate it into the clinic. We're also going to talk about in this course a lot of barriers that exist in our profession to learning these skills and integrating into clinical practice. And then we're really going to talk, this course is a lot about patient-centered communication as an overarching theme for PIP. So look forward to having you purchase this course and learning some new ways of dealing with a really tricky problem.